Dr. Kellyn Moran will be talking about her potential dissertation topic. So feedback, critical feedback is welcome. She's at a place where she's really trying to think about whether or not this idea works. And so any input you can provide now will be very helpful. Dr. Moran is a graduate of the PharmD program here at UIC. She did a 2-year fellowship with Takeda and is currently in the 3rd year of the PhD program here. So be mean to her.
I said that you could do that. It's fine. I know most of you. So thank you for the introduction, given that Dean Schumach isn't here. But thanks for coming, everybody. As Dr. Lee said, this is going to be mostly a review of a lot of the literature that I've been reviewing in preparation for my dissertation. So my seminar title today is Observational Research Assessing the Safety of Chronic Opioid Use in Cancer Survivors. So it's going to mostly be a discussion of the literature and the gaps, and I will go into my research aims that I've developed at this point, but I'm looking for your honest feedback. So just click here. Okay, so to get started, I want to talk a little bit about the cancer survivor population in the United States. So as of 2016, there's estimated to be 15.5 million cancer survivors in the United States. And as you can see from the graphic, this is a trajectory projection out to 2040. You can see that the prevalence is expected to increase greatly. Some of the factors that are associated with this increase are things that you'd probably expect. We have an aging population and cancers typically associated with older age. We also have an increasing incidence of new cancers, but also our treatments are getting better and our cancer screening is getting better, so people are living longer. So if we drill down a little bit further and think about who these cancer survivors actually are, we first see that actually a lot of the cancer survivors are what you would maybe consider a long-term cancer survivor. So they've survived beyond 5 years or 5 years or longer from their diagnosis. And currently about, and I don't have my speaker notes, but it's over 60% of patients who are cancer survivors have survived more than 5 years. And then you wouldn't, not surprisingly, but also the cancer survivor population is older. 62% of the population is 65 and older, and that's projected to go up to about 3/4 of the population by 2040, which you can see here. These top 3 colors are your population 65 and older. So it's predominantly dominated by elderly patients. And when we think about which sorts of cancers are most common among this population, 2 of the most common are colorectal cancer and breast cancer. Again, this isn't really surprising if you know anything about what the highest incident cancers are. These are 2 of the top 3 most common cancers. And it's not just incidence that contributes to their high proportion of or high representativeness in the cancer survivor population, but it's also because they have pretty good 5-year survival or survival overall. Especially if diagnosed early. So if you look at the 5-year survival for breast cancer, it's 9. If diagnosed at early stage, meaning usually stage 1 or stage 2, it's a 99% 5-year survival. And colorectal cancer, it's about 90% if diagnosed at stage 1 or 2. And granted, there's fewer patients with colorectal cancer who are diagnosed at that early stage. It's only about 40%, but it's still, if it is diagnosed early, it's the outcomes are pretty good. So the reason I point out these 2 types of cancer specifically is because when we think about cancer survivor, the needs of a cancer survivorship population and the research that's necessary in this area, which I'm going to talk about a little bit more, it's important to consider the needs for all cancers, but given that these are highly prevalent, specific issues related to these 2 are important to address. So why do we care about studying cancer survivors? And it really comes down to the fact that they have very unique healthcare needs and that they've really been an understudied population until the last few decades, until we have really seen a growing population of cancer survivors. As you all are aware, cancer is a really life-altering experience, and it's associated with a lot of physical and psychological consequences, and these can last, and these can be lifelong. So things that you're probably commonly aware of, like, for example, pain, fatigue, bone loss, anemias, are common physical symptoms, as well as anxiety, depression, fear of recurrence, are common psychological symptoms. And then there's other things like financial issues, spiritual well-being, et cetera, that all comes into play. So it's important to be considering these aspects when we think about cancer survivor care, as opposed to just care of, for example, someone who's over the age of 65, because they have some unique needs. And historically, we've focused so much on the improvements in diagnostics, treatment, and managing, getting patients to remission, and not so much on sort of these secondary sequelae that occur among cancer survivors. So these are important aspects to take into consideration when we're trying to improve the quality of care for these patients, essentially. So, why specifically do we care a lot about monitoring and managing these long-term effects? And that's because at least 50% of survivors are estimated to have them, although it's really variable depending on the cancer or the treatment. Two of the most commonly reported either long-term or late effects of cancer are pain and emotional distress. And these have some interrelatedness, but I'm going to focus first on the issues of pain. So 40 to 50% of cancer survivors have pain after curative treatment. So I'm not really specifically talking about patients who have terminal illness or who have late-stage disease. I'm talking about patients who undergo curative treatment. So this could include early-stage patients. The types of chronic cancer pain that are present in the cancer survivor population are usually thought to be related to either the tumor itself or related to the treatment. And more commonly, we're talking about treatment-related complications in long-term cancer survivors. And I'll talk a little bit more specifically about what these are and how they manifest in survivors of breast and colorectal cancer in just a few slides. But ultimately, there's significant consequences of chronic pain. It causes significant distress, impaired functioning, and reduced quality of life. So it's an important fact to address. So chronic pain in breast cancer survivors is actually maybe more prevalent than you would think. It's estimated to be between 25 and 60%. Most of these patients, which I'll show a graphic in a minute, receive the early stage treatment. The patients who are diagnosed at an early stage typically receive surgery. The common complications of pain-related complications for these patients include post-surgical syndromes, notably like a post-mastectomy syndrome, which is kind of similar to like a phantom limb pain, lymphedema. As well, a lot of these patients will receive some radiation, and we know that the effects of radiation can impact the nerves and the bone. Probably the most well-recognized cancer-related pain syndrome, which can happen in breast cancer survivors as well, as chemotherapy-induced neuropathies. And then for certain eligible patients who have breast cancer, hormonal therapies, which are usually taken for 5 or 10 years after cancer diagnosis to prevent recurrence, can cause things like tamoxifen or aromatase inhibitors can cause arthralgias. So this is just, I won't spend time on this, but this is just a graphic showing you what the common treatment strategy is for early stage breast cancer. So if you look at the one on the left, all the blue bars here show the most common treatments for early stage breast cancer, which is breast conserving surgery plus radiation. Alternatively, patients will have mastectomy. So these sorts of post surgical complications are common, and potentially some radiation and chemotherapy related effects. So the evidence for the chronic pain in colorectal survivor, or the prevalence, of chronic pain in colorectal survivors, cancer survivors, a lot of words, is lower than in breast cancer. It's first of all, it hasn't really been well characterized. The pain syndromes aren't really as well defined as they are in breast cancer, but it does seem that their prevalence is much lower. And this probably relates to the treatments that they get. While surgery is the most commonly indicated treatment for early stage colorectal cancer, there's less addition, especially for colon cancer, of things like radiation and chemotherapy at a very early stage. But it is possible that patients could get these and therefore could have chronic pain related to these treatments. And here you can see the most common treatments for colon cancer, which is on top, and rectal cancer, which is on the bottom. As you can see, 84% of colon cancer patients who are diagnosed at stage 1 or 2 get colectomy and nothing else. It's a little bit more variable when you look at rectal cancers. So you might be wondering when we're thinking about these early stage patients, is like chronic pain really an issue? And I mean, I've showed, so not only do we see some prevalence estimates in the literature, there actually was a recent study that looked at new persistent opioid use among patients with cancer who underwent curative intent surgery. And there really hasn't been too much investigation into what the pain looks like for these early stage cancer patients specifically, and in conjunction with the treatments used. So, for example, opioid use, which I'll expand on in a little bit. But this was a study that looked at adult patients who had cancer who underwent surgery for common treatments that you see with colorectal and breast cancer. So lumpectomy, mastectomy, colectomy, rectal resection. And they did see that among patients who were previously opioid naive, there was a 10.4% risk of new persistent use at beyond 90 days from surgery. So while this doesn't necessarily scream chronic use, because there is some argument to when you would consider how long someone should be eligible for how long you would expect someone to have pain post-surgery. However, this suggests that some of these patients do have continuing pain, and therefore the management strategies associated with that need to be explored. So how should chronic pain be addressed in cancer survivors? And when I went into the literature, I've found that there really isn't very much attention on this issue at all. There's a lot of literature out there on appropriate management for cancer pain, specifically active cancer pain, or end-of-life care, terminal cancers, as well as we all know that in the context of the opioid epidemic right now, there's a lot of discussion about management of chronic non-cancer pain. However, this seems to be a group that's overlooked. There really were no guidelines to recommend, modes of treatment to providers until ASCO came out with a guideline in 2016, and they basically identified that there's really no good evidence to support which sorts of therapies you should use, except for the issue of the utilization of duloxetine for chronic or chemotherapy-induced neuropathies, which has some pretty good evidence. None of the other agents really seem to have strong evidence for specific types of cancer syndromes. And really, they ran into the issue of just not having data that was long enough data looking at the safety and efficacy of these treatments. So they do talk about the options for using non-pharmacologic interventions. They found that the evidence was, quite weak to modest for its effect. There's some discussion and some decent evidence for certain types of non-opioid analgesics. So that's your NSAIDs, your Tylenol, the duloxetine and other antidepressants, as well as anticonvulsants. And then there was, of course, discussion of opioid use as a potential option. Given that we know that opiates work well in cancer pain and they're a well-accepted treatment of cancer pain, there's an acknowledgement that these might be appropriate treatments for certain select types of patients who will become cancer survivors. But when we think a little bit further about this issue of the role of opioid use specifically in the management of chronic pain in cancer survivors, it's kind of a complex issue because on one hand, as I already mentioned, we have opiates are acceptable treatments for cancer pain. They're acceptable treatments and well-established treatments in the use of in palliative care, as well as for immediate post-surgical needs. So on one hand, chronic cancer survivors with a history of chronic pain who they have similar etiology to their pain. We know that their pain is related to their treatment. We know it could potentially be related to their disease, so there's similarities there. And there's an argument that these should be available to patients that no other options work for, or for which no other options work. However, there's a discussion in the literature about the complex issue here with the lack of evidence on the efficacy and safety of chronic opioid use in general. And this comes a lot from the pressures from the chronic non-cancer pain guidelines, where we're starting to learn a little bit more and more that there's some questionable evidence about the safety and efficacy of long-term use of opiates in this population. So thinking about where cancer survivors with chronic pain sit between these two sort of camps is a sort of a dilemma in a sense. Ultimately, what the literature suggests and what the guidelines recommend are that really they give quite vague recommendations, but really that the evidence isn't there. So the recommendation is conservative, that for cancer survivors with chronic pain, opiates should be reserved for those who don't respond to more conservative therapy, and then it's always important to weigh the risks and benefits. And specifically for opiates, the need to use universal precautions and think about some of the more harmful effects of using these drugs long term. So I kind of already talked about this, so I'll skip over it mostly, but that this management, the role of opiates in the cancer survivor population kind of sits at like this cross section of appropriate management of cancer pain and some of the external pressures of the issues with the opioid epidemic. We know that a big concern is that opiates do seem to be are associated with misuse and overdose. And their long-term efficacy and safety is limited. The data for their long-term safety and efficacy is limited. But this hasn't really been studied in cancer survivor populations. And on the other hand, opiates are, of course, a fundamental treatment in the management of cancer pain. And we also have the issue of a historical problem of undertreatment of cancer pain, and therefore there's been large efforts over the years to destigmatize the use of opioids for cancer. So it's sort of a competing effects here. So what would be the implications then for cancer survivors? So it seems that there may be a reluctance, according to discussions in the literature and some of the evidence that is out there, that there's a reluctance potentially to acknowledge some of the risk of opioid misuse or overdose among cancer survivor populations, given that their etiology of pain is cancer related. And there's some thought, it's more of an older thought, that the risk of some of these outcomes, like the ones that we're concerned about with chronic non-cancer pain, specifically misuse and overdose, would be low if opiates are used appropriately. And certainly it's not really considered appropriate to be concerned about some of these issues when we're talking about end-of-life care or acute pain. However, the problem here is that cancer is more commonly becoming more similar to a chronic condition, and therefore long-term opioid use for these patients might be a reality, but there's really no evidence on the risks associated with their use. There's really no evidence to either support or refute that there's a risk of misuse or overdose in cancer survivors. And what I found is that, and what we all know from it, having read any literature on related to the opioid epidemic, any study looking at these risks usually just excludes patients who have a history of cancer. They don't usually specify whether or not it's specifically active cancer. So it could be patients who are, well beyond original therapy. And it's not to say whether or not one is right or wrong, but the risks have just not been explored, and the data for the risk of these complications in cancer survivors is just extrapolated from non-cancer populations. And given the complexities of these cancer survivors, you could argue it may or may not be appropriate to do that. For example, and one of the issues that I'm going to explore a little bit more with some of my research aims, we know that there's high overlap between emotional, psychological conditions like anxiety and depression in cancer with pain, and these factors are more prevalent among cancer survivors, and therefore, and we know that they're associated with the outcomes of interest, so misuse and overdose death, and therefore should be explored in the context of the population for which we would be making recommendations for. So overall, what I found was that there's really a lack of evidence for appropriate medication management for chronic pain in cancer survivors. There is limited information describing the use of opiates among early stage breast and colorectal cancer survivers. Again, my focus on this group is that they are prevalent cancers with high survival. They have similar treatment modalities, commonly surgery, and they're expected to return to relatively normal function after having curative treatment. So, and that the risk of opioid misuse and overdose, along with the influence of factors like psychiatric comorbidities, specifically anxiety and depression, should be explored. So, so now I'm going to talk a little bit about my proposed research aims. So the overall objective is that I'd like to describe the patterns of chronic opioid use among survivors of early stage breast or colorectal cancer and evaluate the risk of opioid misuse and overdose in these populations. Now, some of the epidemiologic data that I showed at the beginning uses the most common definition of cancer survivor, which is really just anybody from diagnosis for the rest of their life. However, what's commonly used in research and what I'll be using for my definition will be patients who are post-active treatment for cancer, which I'm going to operationalize based on 1 year post-last treatment to be defined as a survivor in my cohorts. So the first aim is that I'd like to describe the population level trends in incidence and prevalence of chronic opioid use episodes among early survivors of stage 1 or 2 breast or colorectal cancer, and observe how these trends compare to a population of patients without a history of cancer. My hypothesis is that chronic opioid use will have increased over time, that the prevalence of use will be higher among cancer survivors compared to patients without a history of cancer, and that we would see a slowing rate of increase after 2010. So I'll talk a little bit about my conceptual framework for this. So I'm sorry if you can't really see this. I'll talk it through. So factors, when I'm thinking about factors that would influence the incidence and prevalence of chronic opioid use in the general population, not with a history of cancer, we know, well, first of all, we know that this is an increasing trend. And some of the factors that are related to this are the fact that we know that chronic pain is increasing. There's not very good alternatives for pain. Opiates seem to work. Opiates have a are biologically associated with physical dependence, tolerance, and addiction, so it can affect the utilization over time. And also a lot of issues at the bottom here, this big one is the issues related to overprescribing, the provider's role in the utilization of chronic opioids. Things like lack of knowledge how to treat, lack of evidence-based guidelines, lack of knowledge of how to prescribe and when to prescribe, or how to taper off. So factors like that. So while I would expect to see that the trends of the incidence and prevalence of chronic opioid use would be increasing the general population, how would I compare that to a cancer population? So The reason I think that it would be higher is because of some of the additional factors associated with cancer survivors. And most notably, the issue is that these patients just have more pain. They have, in addition to having general comorbidities similarly to the rest of the general population, they have had treatment or a tumor, something that is causing some sort of like a distinct cause of pain. Also, there's other factors. Cancer survivors are known to have a higher psychological distress, which is associated with chronic opioid use. They also have a complex set of interactions with the healthcare system. They're potentially at risk for more uncoordinated prescribing. The issues with cancer survivors is one issue with cancer survivors is who manages these patients. Is it the oncologist as they transition to survivorship, or is it the general practitioner? And that could complicate the prescribing of opiates. And then there's some other issues related to the fact that that I mentioned before, that we don't want to discourage cancer patients from seeking the medications that they potentially need, and that as they transition to survivorship, there's no defined time necessarily, no clear defined time of when it's appropriate to stop the medications, or it might vary a lot. One maybe conflicting factor, which is potentially why I think that we would potentially see a slowing rate of increase over time, especially after 2010, would be because there's been so much more scrutiny over opioid use. And I think that could potentially affect a cancer survivor population just as much as it would affect a general health population. So the method that I want to use to look at the incidence and prevalence of chronic opioid use episodes is a cross-sectional time trend analysis. I propose to use the SEER Medicare link database, and I'll be looking at adult patients 66 and older who are diagnosed with stage 1 or stage 2 breast or colorectal cancer. And I will have a concurrent cohort of patients who are without cancer. I'm not doing a direct comparison. I'm planning to observe the difference and observe the trends concurrently. So to be included in each cross-section year of the analysis, each patient would have to have the cancer diagnosis on or before the year of interest, and then obviously have appropriate enrollment so that we could assess their utilization. So I'm proposing to measure opioid use based on an episodic definition, where I would be measuring opiates. I would be looking for new opiate use without prior use in the 6 months prior, all the way until they discontinue use, which would be defined as the last opioid prescription with another 6-month gap. So patients can have multiple episodes of opioid use over time, but I'll be defining it in this manner instead of just looking at single prescriptions. Other things that I'll be measuring, and I'll talk a little bit more about how I want to classify this. Other measures that I want to take a look at are things like the type of opiate or the most common opiate used in the episode duration, day supply, morphine equivalent, and then average daily or prescribed dose, which is essentially based on the morphine equivalent calculation. So I want to classify these episodes in 3 ways, and my primary aim is to identify chronic opioid use, but I'll define them based on a combination of the length of the episode, as well as either a metric of the quantity that they receive or the numbers of prescriptions. So chronic opioid use would be an episode lasting more than 90 days and having more than 120-day supply or more than 10 prescriptions over the following year. So ultimately, I propose to describe the characteristics of the cohort, in the incident in the first year in 2008, as well as in the last year, and ultimately look at the proportion of patients, the age and sex standardized rates of prevalent or incident chronic opioid use episodes within each year of interest and trend them over time. So essentially, someone would be categorized as having an incident episode if they started the episode within that year. They would be categorized as having a prevalent episode if they began in the year in the years prior. And I would look at percent annualized change in the rates over time. And I have a couple of proposed secondary analyses, like looking at different trends and some of those other metrics that I mentioned that would be interesting to measure, including looking at dosing or duration or morphine equivalents specifically. So I'm going too fast. So the second aim, I'd like to identify clusters of individual level trajectories over 1, 3, and 5 years among elderly survivors of stage 1 or stage 2 breast or colorectal cancer. I have a couple sub-aims here. So I propose then to identify the demographic and clinical factors that are associated with trajectories of opioid use, as well as to evaluate the association between the opioid use trajectories as well as misuse and overdose. So my hypothesis is that there's going to be distinct trajectories of opioid use among cancer survivors, and that they'll be associated with different demographic, treatment, and clinical profiles, and that each will be associated with a different risk of misuse and overdose. So I propose to address this aim by doing a retrospective cohort study using group-based trajectory modeling. Again, I'd like to use the SEER Medicare linked database, and I'm looking at an adult population diagnosed with breast or colorectal cancer. For how I'll calculate, in order to do group-based trajectory modeling, I have to have a measure of calculating opioid exposure. And to do this, I'll be taking the morphine equivalents for each dispensing and then looking at the morphine equivalents for each day supply and creating arrays of opioid exposure, and subsequently dividing follow-up time into 30-day windows where I look at the opioid exposure in each of the windows, and you create individual level trends in opioid exposure. It's like a cheer. Anyways, so group-based trajectory modeling is unique because what it does is it takes these individual level patterns of opioid exposure, and then it uses a method of sort of clustering the patients into similar sets of longitudinal courses of opioid exposure. Once I've done that, I would want to characterize the patients who who are most likely to belong to each trajectory, and determine which factors are significantly or are potentially associated with these trajectory memberships. I would like to explore this over longer trends, but I'm a little concerned about data issues here, but it would be a proposed secondary analysis. So here's where I'm hoping to get a lot of your feedback. So as part of the second aim, I'd also like to look at the association between opioid use trajectories and the risk of opioid misuse and overdose. So I'm proposing to use a case control design. Essentially what I'd like to do is I'd like to identify patients specifically, for example, who have overdose, and then look at the association between that case definition and trajectory membership. Now, in terms of definitions for my outcomes, overdose, because I'll be using the SEER Medicare data, I have the opportunity to use linked death registry data for identifying opioid-induced overdose, as well as claims-based algorithms using the Medicare data. However, at this time, I'm a little unsure of how I want to approach the issue of misuse, specifically because of limitations of the data. The fact that I would have to identify it using a claims-based algorithm, and I may be missing some important variables which have been historically used to define misuse in claims-based databases, like knowing the prescriber, for example. And additionally, a challenge is thinking about the time frame. So in order to measure misuse, you need to it needs to be like a longitudinal window of time. And where on one hand, I'm already looking at a trajectory I'm at the moment trying to determine whether or not I can use that outcome to then look at a previous utilization structure or opioid utilization pattern. So I guess I'll finish up with my third aim, and maybe we could come back to that. Okay, so my final aim is to examine the interaction between prescriptions for opioids and the diagnosis of anxiety or depression on the risk of overdose among elderly survivors of stage 1 or 2 breast cancer, stage 1 or 2 breast or colorectal cancer. And my hypothesis would be that the risk of overdose is greater among cancer survivors with a history of anxiety and depression. So again, I'm still working through the development of the methodology for this aim. I'm thinking of using a retrospective cohort study, potentially thinking about using some time-varying exposures to assess when patients have an opiate versus not having an opiate and different metrics around that. So looking at maybe quantity of opiate or morphine equivalent, et cetera. And then I plan to do an interaction analysis looking at the impact of having the presence of an anxiety or depression diagnosis. Essentially what I'm looking for is I'm looking to explore sort of something like this where we can see the differential risk from patients. So this is the risk of opioid overdose among patients. The top is who have depression versus not. So essentially like that, but I'm still in the process of developing the methodology. So ultimately, the implications of this research, given there's really a lack of data available exploring the issues of either use in general or the risk of misuse and overdose in this population. So because there's a lack of evidence, there is a need to do some exploratory research to understand these trends and what the associated factors are. Ultimately, this work will help to identify and quantify the risk of misuse and overdose in this population, which hasn't been done before. And it's necessary to support clinician decision-making and developing guidance for risk stratification. Currently what's available are the risk stratification tools for chronic non-cancer pain. What are the modifications that might be necessary when we're thinking about a cancer survivor population where they're sort of at this intersection of having cancer pain but needing to use a product long-term? There's a number of limitations potentially to this research. A big one potentially might be sample size. And I don't have numbers estimated for whether or not what I'm proposing is feasible, but obviously overdose is a rare event, which is going to be a potential issue. Also, some other things that you might expect, use of claims, not capturing cash-based opioids, also not being able to really attribute opioid prescriptions to a pain diagnosis. That's a pretty significant problem with really all this research. It's not easy to know exactly why they're taking it. I won't be able to know if they're taking it for a specific pain syndrome because they're either not well defined and then they're certainly not coded. I don't think that it would be much better even in the EHR just from the sort of ambiguity sometimes. Certainly certain conditions like lymphedema or maybe chemotherapy-induced neuropathy you might see, but this is a limitation. And then finally, a big limitation that I've faced in developing a dissertation focusing on this topic is, a lot of the questions that I think I'd like to answer require a good comparator. And what I've really found is that there's no good comparator between cancer survivors and, for example, another like non-cancer pain condition. So in terms of making direct comparisons between these two populations, it doesn't really seem quite fair. So that's a limitation potentially for understanding any questions when we think, how do they differ from the general population? It seems I can only study within the cancer population. So I sped through that. I'm sorry it was too fast, but I'd really appreciate any comments you have or questions.
So Kellyn, one of the biggest questions I have, and something that I think needs to be outlined a little bit more here.
Yeah.
The theoretical framework that you propose.
Yeah, I'm going to get it.
Sure.
Okay.
So the theoretical framework that you're proposing is really around what factors contribute to opioid prescribing. But the questions that you're answering have more to do with the outcomes associated with opioid prescribing. And so your theoretical framework isn't extended far enough. It doesn't describe how people become dependent, don't become dependent.
Okay.
How dependent impacts mortality or not. And those are the questions you're actually answering. So when you're done with this, you're not informing very much other than overall opioid use, just sort of the first aid somewhat addresses some of the things.
Yeah.
But I think you would be proposing very different questions if you were looking at you'd probably be looking more qualitative type of research to find out why people prescribe what they do, why patients agree to take medications, if you were truly trying to look at the current model that you proposed.
Okay.
Is there anything on how long the pain lasts typically? So you could try to distinguish over use of the drugs, beyond the typical pain window, something like that?
So I know it's a big problem is that the pain syndromes are not really well defined in general. But for example, the study that looked at pain post curative surgery, I mean, they utilized the metric was based on surgical guidelines that say after surgery, after 30 days, you should not need treatment. But maybe that could be applied to this population, because if I'm looking specifically at early stage breast and colorectal cancer, where that's the treatment that might be appropriate in that case.
There might be subsets, at least, to focus on that, where you have a pretty good clinical idea that anything beyond 30 days is more like addiction rather than continuing pain.
Yeah.
Because that's what you're trying to distinguish.
Right. Yeah, and it's also complicating my definition of misuse, because there's not a lot of good definitions for how that's different than what you would expect in the general population, too. So.
I mean, it's a great area because it's really topical. There's obviously a lot of misuse in opioids and a lot of risk associated with that. So I do think it's something that's interesting to look at. You want to try to make the analysis so you can inform a decision or a policy a little bit more. I do think you'll be able to see the extra risks associated with opioids if you have a large enough sample of overdoses. So you'll get that for sure.
Mm-hmm.
You'll see some interesting trends. When you say trajectories, what do you mean there? Do you have some specific definitions of trajectory?
Yeah, I mean, so essentially it's going to be a trajectory of opioid, like 30-day opioid exposures over time. Like individual level patterns. It's sort of like a latent class.
Trajectories. One of your aims is to measure trajectories. Which I can sort of
imagine
how that might be defined. But
I see what you mean. Oh, maybe I should say more like patterns. But
growing over time,
it's
over time, staying constant over time. That's what you mean. Right?
Yes.
Being a little more specific.
Okay.
Yeah. Well, and it sounded like it was somewhat related to morphine equivalent doses. So are the trajectories about dose over time, or is it adherence over time? Because most of the GBTM work that I've seen is in adherence, but I'm not sure how you would bring in the concept of morphine exposure or dose, opioid dose, into that discussion. Because there's sort of two things going on there, right? There's whether someone is taking it regularly, and then there's the dose that they're taking it. Either of those, again, an explanatory model would really help. Either of those two things may be associated with improper use of opioids.
Yeah. Okay. Yeah.
Actually, what's similar to what's
Never mind. Have you thought of other data sets, maybe electronic health record kinds of data that might be smaller sample, but you could do something more qualitative and trying to identify misuse and maybe tie that to claims? Because if you could come up with some kind of way to form some kind of claim-based algorithm that was validated somehow, that would be big. I don't know if you can, but maybe a UIC electronic health record or UHC electronic health record, you could try to build a map or something, or at least identify, if you had that data, how you could identify misuse.
You're talking, yeah.
That's different than kind of these main questions.
Well, right. I mean, I actually had another aim that I've sort of just stepped away from, I guess. I mean, not totally, but it's in the back of my head, about like something like there's a need for sort of these like prediction models too for this type of stuff that's maybe specific to this population. So it would be good not only just for me to be able to measure, but I think it would also be like a valuable contribution too in terms of looking at, like actually going into the EHR records and seeing if we can validate it.
Or if you can just identify clear misuse in the EHR, even if it's coded or something.
Yeah.
That might, it's easier said than done.
I am working, working with some clinical people here, so I'm hoping to sort of, get their input as well about like some of those other options in terms of data sets. But that's a really good point. I mean, I think that there might be, I might be able to better answer some of the questions that I'm trying to if I use the data set, the different data set. Yeah.
Shoot you a question.
Oh.
Yeah, I've thought more so. I was wondering if you considered, I know finding a comparison group has been something you've been thinking about.
Yeah.
Given the background that most of the pain may be driven by the surgery, which is the main treatment for acute cancers.
Yeah.
I was wondering if there may be if you thought about any intensive surgeries in the non-cancer population as a potential comparison group. I don't have Google right now, so I can't really look. But I'm pretty sure there's other intensive surgeries that you can like form a comparison group.
Yeah. I mean, I don't know off the top of my head, but that's a really good point. I mean, maybe like, could you just look at regular colectomy in like an IBD population potentially? I don't know, but
you'll still have that
similar.
They could have more pain because it was cancer, but I mean, if you find intensive surgeries, then maybe you have a decent comparison.
No, that's a good point.
For neuropathic pain population, it's a non-cancer neuropathic pain population. Then you also have a potential treatment comparator in like Lyrica pregabalin.
Right. I thought about that, but I have been reading a little bit in the literature about the argument that the neuropathic pain, and I haven't validated this with a clinician or anything, but from what I've read is that the neuropathic pain is actually potentially different. But I mean, it's of the same vein here, I guess, but that it might have more inflammatory factors around it that might make it worse. And I don't know the actual biological mechanism, but yeah, right. And that's at least a well-defined one, whereas a lot of these other syndromes don't seem to be well-defined, and I feel like that one's quite clear. So no, that's a great point. Okay.
Sorry, next question.
Yeah.
Kellyn, I was just thinking about you picked breast cancer and colorectal cancer. So
yes.
I'm just thinking about breast cancer, for instance. Like you're going to end up stratifying these two groups, and then I assume you're doing both cancers so that you can enhance your sample size.
Yes or no. I think that.
So it's something to think about because in the end you'll do your analysis twice probably, and then you'll combine them so 3 times. But really, when I think about breast cancer as how appropriate it would be to try to investigate this research question, for instance, and I agree with the point that cancer has transitioned some of them into being treated more like a chronic disease.
Mm-hmm.
But it seems to me like prostate cancer might be more appropriate than breast cancer for reasons that like breast cancer, generally you treat it until it's gone, right?
Right.
And then, and just based on my family experience and the reading that I've done, it's like the opioids being treated, a patient that's on opioids long-term when they've been diagnosed with breast cancer and had resolution, just seems like it's inappropriate use of opioids. Whereas if you were to look at prostate cancer, it may be appropriate because of watchful waiting. So it may serve its purpose if you have if you look at breast cancer, and then you consider all of the continued use after whatever kind of indicator you can find in terms of treatment resolution, and characterize patients in that way, whether or not they're using opioids or not. But then the trajectory, I don't know, that's very constructive as a research question. So I just think that you're going to have to think carefully about the type of cancer, the way that opioids may or may not be appropriately used in that group, and then how much sense your research questions make in the context of those two other factors.
Thank you.
One other little small thing is with depression, were you going by ICD codes for that?
Yeah, and that is another limitation. I know that they're notoriously non-specific.
Well, a lot of times.
Or underreported.
Exactly.
Well, that one, I mean, would that be something, though, I could explore in the EHR? Like, if I were to change data sets a little bit, would that be a better opportunity? Or you think it's still not even reported?
You know, honestly, Kellyn, I know more about it in the primary care setting, where in the primary care setting, they just don't routinely screen for depression. And like I work in diabetes, about half those folks have depression. And I can tell you about 10-15% are diagnosed and treated. So it's a problem across different diseases. I still think it's an interesting question, but it's just another kind of difficult thing. They're going to diagnose them most likely when they treat it. And then you don't know if the depression subsided or not.
Right.
And I don't know if that matters to you or not in your theoretical underpinnings of that hypothesis or not.
Okay.
This is a really interesting area, and I think it's really, really important. And I think because so few people have looked at it, that's part of why you're struggling with this, and maybe why some people haven't looked at it either.
Yeah, it's not feasible. No. We'll see.
You got some good feedback, though.
Yeah, no, I really appreciate it. Thank you, everybody.
Feel free to look her up on your own if you have more feedback.
Yeah.